Imagine waking up from a successful, potentially life-saving surgery.
Right.
The anesthesia is wearing off, right? The nurses tell you the procedure went perfectly, and you feel that overwhelming wave of relief that you are going to be okay. But then a few months later, a piece of mail arrives. It's a bill for $20,000.
Wow. Yeah.
And it's not from the hospital you carefully selected, and it's not from the surgeon you vetted. It's from the anesthesiologist who monitored your breathing.
Right. A doctor you never actually met while conscious.
Exactly. A doctor you never met who just happens to be an independent contractor not covered by your health insurance. Yeah. So, because you were asleep, you legally consented to a catastrophic financial debt.
It completely reframes the definition of a medical emergency, doesn't it?
It really does.
Because the biological crisis is resolved, but it is immediately replaced by an administrative and financial crisis. And that could follow you for a decade.
Right. So today, for those of you listening, we are looking at the American healthcare system, and we're doing it through a very specific and frankly fascinating lens.
Yeah, this is a great source.
We are analyzing a transcript from a C2 Advanced English Learning podcast. It's hosted by two instructors who designed this specific lesson for non-native speakers, immigrants, and long-term visitors.
What's interesting is they aren't just teaching high-level English vocabulary here.
No, not at all.
They are teaching the mechanics of U.S. healthcare as an absolute, non-negotiable survival skill.
Yeah, the pedagogical approach of the source material is really what makes this so compelling.
Right, because the instructors are spending an hour defining words like deductible, coinsurance, and in-network. And the underlying implication there is that this vocabulary is so crucial and the consequences of misunderstanding it are so severe that mastering it is basically as important as learning how to call the police.
Or like finding a grocery store, yeah. And it raises an interesting point right up front. If native-born Americans routinely struggle to understand what a provider's adjustment or an allowed amount means.
Constantly.
Right. So the fact that we are expecting newcomers to master this jargon reveals that this isn't just a language barrier.
No, it is a systemic barrier. The vocabulary itself is the gatekeeper.
Exactly. Which is why our objective today is to break down those dates. We are going to extract the hard facts, decode the bewildering financial terminology, and, map out the survival strategies embedded in this source.
Because for anyone interacting with the U.S. system, whether you are planning a move, studying international policies, or simply trying to understand how this ecosystem functions, treating healthcare as a passive experience is incredibly dangerous.
It really is a massive gamble. But before we go any further, we do need to establish the ground rules for this deep dive.
Always a good idea.
Yeah. The source material we are pulling from contains very strong perspectives. The instructors explicitly refer to the American system as broken, expensive, and unfair.
They definitely have a viewpoint.
They compare government-run, universal healthcare models against private for-profit models, which inevitably touches on highly charged political debates.
Right. So we need to be clear to you listening.
Yeah.
We are not taking a political stance.
Exactly.
We are not endorsing a private market over a single-payer system or vice versa. We're not doing that.
No. We are strictly here to act as your analytical guides. We are reporting on the mechanics of the system exactly as presented in the SORT documents.
We'll look at the incentives, the math, and the economic realities, right? But without editorializing on whether those realities are morally right or wrong.
Our goal is pure clarity.
And achieving that clarity requires us to establish a baseline. So the source material begins by addressing the profound cultural shock that international visitors experience.
Oh, it's a massive shock.
It contrasts the United States with countries that utilize universal healthcare. They specifically cite the UK's National Health Service, Canada's single-payer system, and Germany's statutory health insurance model.
Let's look at the social contract in those countries for a second. The source summarizes the universal experience like this. You break a leg, you go to the hospital, a doctor sets the bone, and you walk out.
Right. The transaction is fundamentally and almost exclusively medical.
Like your status as a patient is the only variable that matters in that building.
Exactly. The shift required when entering the U.S. system is moving from the mindset of a citizen receiving a public utility to a consumer purchasing a private product. In America, healthcare is a commodity. It's managed by private corporations, delivered by private entities, and subject to the economic forces of a for-profit market.
So If we take that exact same broken leg and place it in an American context, the sequence of events changes drastically.
You break your leg. Before a doctor examines the fracture, administrative staff must verify your insurance network status.
Yes, assuming you are even conscious.
Right. And you're asked to provide a credit card for an upfront copay. Weeks after the bone is set, you receive itemized statements.
And you might have to dispute charges.
Yeah. And if the coverage is denied or the math just doesn't work in your favor, the source points out that you are looking at potential bankruptcy.
The stakes literally could not be higher. The source highlights a data point that is crucial for understanding the sheer scale of the financial risk here.
What was the number?
Medical debt is the #1 cause of personal bankruptcy in the United States.
Number one.
Number one. It affects approximately 530,000 families every single year.
Wait, I need to push back on that number for a second. Over 500,000 families file for bankruptcy every year because of medical bills.
Because the immediate assumption most people would make, myself included, is that those 530,000 families simply didn't have health insurance. Like, they took a risk, they lost, and they went bankrupt.
Well, that is the logical assumption, but the source emphasizes a detail that truly shocks international observers. The vast majority of those bankruptcies happen to people who actually have health insurance.
Wait, really? How does the math on that work?
It's a structural thing.
Because if I have an insurance policy, isn't the entire point to insure against bankruptcy? Are we talking about a scenario similar to, like, buying car insurance?
That's actually a really good way to look at it.
Like, you pay your monthly premium, you keep your proof of insurance in the glove box, but if you get into a major crash, you still have to pay a deductible.
Right.
Your rates might go up, and the insurance company might argue with the auto shop about using generic parts versus original manufacturer parts. So you buy it to prevent total ruin, but the repair isn't free.
The car insurance analogy illustrates the mechanism perfectly. Health insurance in the U.S. operates on the principle of risk mitigation, not comprehensive prepayments for unlimited services.
Okay.
You are purchasing a financial product designed to cap your absolute worst-case scenario losses.
Right.
But the gap between what the insurance covers and what you are required to pay out of pocket before you hit that cap well, that gap can easily exceed the liquid savings of the average family.
So you aren't buying healthcare, you are buying a financial buffer.
Exactly.
Which begs the question, how do you acquire this buffer? If it isn't provided to you by the state upon birth, how do you enter the market?
This introduces the bureaucratic landscape. For the vast majority of Americans under the age of 65, which is roughly 160 million people, access to health care is tied directly to their employment.
Employer-sponsored insurance?
Yes, ESI.
Tethering biological needs to employment status seems like an incredibly precarious foundation for a system. I mean, if you lose your job, you don't just lose your income, you lose your ability to go to the doctor.
It creates a tremendous amount of what economists call job lock. Employees stay in roles they might otherwise leave, simply to maintain their health coverage.
Wow, yeah.
And the mechanics of ESI involve the employer acting as a middleman. The company negotiates a massive group policy with giant insurance conglomerates.
The source names a few of the dominant players, right? Blue Cross, Blue Shield, Aetna, United Healthcare.
By pooling hundreds or thousands of employees together, the employer secures a slightly better rate because they're spreading the risk across a large group of healthy and sick people.
But the middleman negotiates the rate, and the employee still has to pay the entry fee. And the source introduces the first major piece of vocabulary here, the premium.
Right. The premium is the baseline cost of admission. It is the fixed monthly fee that must be paid simply to keep the insurance policy active.
Just to have a card in your wallet.
Exactly. This fee is due regardless of whether you ever see a doctor, whether you ever fill a prescription, or whether you are in perfect health for the entire 12 months.
The source quotes the average premium for a family of 4 as being between $1,500 to $2,000 a month.
It's huge.
That is a staggering amount of money. That is equivalent to a mortgage payment in many parts of the country just to possess a plastic card that says you are insured.
Now, under the employer-sponsored model, the company typically subsidizes a significant portion of that.
Okay, so you're not paying the full $2,000.
Right. Usually the employer covers 70 to 80%. The remainder is automatically deducted from the employee's paycheck before the money ever hits their bank account.
I see.
So the employee might only feel a $400 deduction, but the true cost of the premium is still that $2,000 figure.
But what happens if you are a freelancer or an entrepreneur? Or like you work for a small business that doesn't offer ESI? The source maps out several other pathways, and they all seem to operate by completely different rules.
It is a highly fragmented patchwork. If you don't have employer coverage, you are pushed into the individual market. This often means using the health insurance marketplace, which was established by the Affordable Care Act, frequently referred to as Obamacare.
Right.
Here, individuals shop for private plans on an exchange. And depending on their income level, the federal government may provide subsidies to help offset that massive monthly premium.
So wait, subsidies to private companies paid for by tax dollars to lower the premium for the individual.
Correct. Then there is Medicaid, which is a joint federal and state program designed for low-income adults, children, pregnant women, and people with disabilities.
But the source explicitly notes a catch there.
Yes, because it's partially state-run. Eligibility requirements fluctuate wildly depending on geography.
So a single mother earning $20,000 a year might qualify for full free medical coverage if she lives in New York. But if she moves across state lines to Texas, she might be completely uninsured simply because the state legislation is different.
Exactly. The zip code dictates the biological coverage.
That's wild.
And finally, there is Medicare, the federal program primarily for citizens age 65 and older. Yet even this is a labyrinth.
Oh, the alphabet soup.
Right. The source details how Medicare is divided into distinct parts. There's Part A for hospital stays, Part B for outpatient doctor visits, Part C for private advantage plans, and Part D for prescription drugs.
So a senior citizen has to navigate which combination of these alphabetic plans they need to survive.
Yes.
We also need to address the specific audience this Source podcast was targeting, international visa holders, because their path is even more rigid.
Absolutely.
International students on F1 visas are generally mandated to purchase specific university-sponsored plans. Professionals on H-1B visas typically fall into the employer-sponsored bucket. But if you hold other visa types, you are thrust entirely into the open market, forced to decode this system without an HR department to guide you.
And this entire structural overview leads to a crucial warning in the source material regarding what they call the premium illusion.
The premium illusion. This seems to be the cognitive trap that catches almost every newcomer.
Oh, without a doubt.
Because if you come from a system where you pay a high tax rate or a statutory health contribution from your paycheck, you naturally assume that payment means the healthcare itself is free when you need it.
It is a logical assumption based on global norms. You pay your dues, you get the service.
Right.
But in the American system, paying that $2,000 a month premium does not buy you a single bandage. It simply buys you access to a negotiated pricing structure.
I want to make sure this lands for you listening. It is functionally equivalent to paying a massive monthly membership fee to an exclusive wholesale club.
Yes.
You pay just to walk through the front doors. But once you are inside, you still have to put items in your cart, and you still have to pay at the cash register before you can leave.
The premium is just the right to look at the menu.
Wow.
And the prices on that menu introduce us to the next layer of complexity. Paying the premium is the static math. Now we have to look at the dynamic math, what actually happens to your bank account the moment you get sick.
Okay, let's decode the vocabulary of the cash register, because the source lays out a sequence of financial hurdles that a patient must clear. The first hurdle, and arguably the most punishing, is the deductible.
Right. The deductible represents the amount of money a patient must pay entirely out of their own pocket for medical care before their insurance company contributes a single cent toward the cost of those services.
Let's run the example provided in the source to see how this friction works in practice.
Sure.
Suppose your health insurance plan has a $3,000 annual deductible. You take a bad fall and require an MRI. The hospital bills $2,000 for that MRI. Because you have not yet spent $3,000 of your own money this year, you are responsible for the entire $2,000 bill.
Exactly. The insurance company processes the claim, notes that it falls under your deductible, and pays zero. Until you cross that $3,000 threshold, you are, for all practical purposes, paying retail prices for your health care, despite having paid thousands of dollars in premiums.
So why does this mechanism exist? If the insurance company isn't insuring my first $3,000 of risk, what am I paying them for? I mean, is it just a way to shift costs onto the patient, or is there an economic theory behind this?
There is a theory. It is rooted in an economic concept called moral hazard.
Moral hazard.
Yeah. The theory posits that if a service is entirely free at the point of use, consumers will overutilize it.
Okay.
So if MRIs cost $0, The fear is that patients will demand an MRI for every minor ache and pain, overwhelming the system and bankrupting the insurance pool.
I have to challenge the logic of that theory when applied to human biology. I mean, I understand moral hazard if we are talking about an open bar at a wedding. If the drinks are free, people will drink more.
Sure.
But nobody wants to go to the hospital. Nobody wants a colonoscopy or a root canal or an MRI tube just for the fun of it.
That is the primary criticism of applying moral hazard to healthcare. It assumes the patient is a rational consumer seeking luxury goods, rather than a sick person seeking necessary repair.
Right.
But from the perspective of the system's design, the deductible introduces friction. It forces the patient to weigh the financial pain against the physical pain before seeking care.
Okay, so the deductible is the first hurdle. What happens if you just need a routine checkup, something that doesn't cost thousands of dollars? Does the deductible apply to everything?
Not always. And this introduces the next vocabulary term, the copay.
The copay.
A copay is a fixed, flat fee that you pay every time you access a specific lower-tier service.
So it functions like a toll booth on a highway.
Yes. Your insurance plan might stipulate a $30 copay to see your primary care physician, a $50 copay for a specialist, or a $100 copay to visit an urgent care clinic.
And you just pay that at the desk.
You pay this fee at the reception desk before you even see the doctor. And crucially, copays often do not count toward paying down your deductible. They are a separate stream of revenue.
So you are paying the monthly premium, you are paying copays at the door, and you are paying down a massive deductible if you need anything major. Let's say you finally hit that threshold. You've spent $3,000 of your own money. The deductible is satisfied. Does the insurance company finally step in and cover everything?
They step in, but they do not cover everything.
That's not.
This triggers the third financial phase, coinsurance.
Coinsurance. The prefix co implies a partnership, like you are sharing the burden.
Exactly. You transition from paying 100% of the bill to paying a percentage of the bill. Coinsurance is the agreed-upon split between you and the insurer for all costs incurred after the deductible is met.
And the source uses a very standard industry split, 80-20.
Meaning the insurance company pays 80% of the negotiated rate, and the patient remains responsible for 20%.
But 20% of an American medical bill is rarely a trivial amount.
Very true.
The source provides a practice exercise to illustrate this, and I want to walk through the math step by step because hearing the percentages in the abstract doesn't convey the reality.
Let's do it.
Okay, let's take their scenario. You require a surgery that costs $30,000. Your plan has a $2,000 deductible. Your coinsurance is an 80-20 split. And let's add the detail that earlier in the year, you spent $500 on minor medical expenses that went toward your deductible.
Okay, let's run the forensic accounting here. Your deductible is $2,000. You've already paid $500.
Right.
This leaves a remaining deductible balance of $1,500. When the $30,000 surgical bill arrives, the first thing that happens is the insurer deducts that $1,500. That is entirely your responsibility.
Okay, so the remaining balance on the surgery is now $28,500. The deductible is finally met.
Yes, and now the insurance company wakes up and applies the coinsurance split to that remaining $28,500.
They pay 80%, you pay 20%.
Right.
Okay, so 20% of $28,500 is $5,700. So to calculate my total out-of-pocket cost for this single event, I add the $1,500 deductible I had to finish paying, plus the $5,700 in coinsurance. So my total bill is $7,200.
Yep.
I am paying over $7,000 out of pocket, despite paying my monthly premiums all year.
And that number brings us to the final safety net in this mathematical equation, the out-of-pocket maximum.
The absolute ceiling.
This is the maximum amount of your own money you can be forced to spend on covered medical services in a single year. The source notes this limit is often around $8,000 to $10,000 for an individual.
Okay.
Once your combined spending on deductibles, copays, and coinsurance hits that hard ceiling, the insurance company is legally obligated to cover 100% of all remaining costs.
Let me clarify a critical timeline detail here. When you say in a single year, does this operate on a rolling 12-month basis, or does it reset on a specific date?
It almost universally resets on January 1st, operating on a strict calendar year.
Wait, so if I get diagnosed with an illness in late November, and I spend $8,000 meeting my out-of-pocket maximum in December, on January 1st, that counter resets to zero.
Yes.
I have to start paying my deductible all over again.
That is exactly how the system functions. The financial protection evaporates at midnight on New Year's Eve.
That is brutal.
It is. A patient with a chronic condition requiring expensive treatments every month will hit their maximum in February, enjoy fully covered care for 10 months, and then face the massive financial hurdle again the following January.
If we synthesize all of this math, the psychological toll on the patient becomes apparent. I mean, the source is entirely accurate to use words like meticulous. You cannot just be a patient trying to heal from a $30,000 surgery. You have to act as a project manager for your own illness. You are tracking calendar year spend, monitoring deductible thresholds, and verifying percentage splits while simultaneously trying to recover biologically.
It requires an active, aggressive vigilance. Because if you assume the system will automatically calculate everything in your favor, you'll inevitably overpay.
But here's the most terrifying aspect of the source material. You can do all of this math perfectly.
Right.
You can pay your premium, satisfy your deductible, track your coinsurance, and monitor your calendar year limits. And there is still a structural trapdoor that can invalidate every single calculation we just made.
The network trap.
Yes. Let's explore how a patient can follow all the rules and still be financially decimated by surprise bills and out-of-network providers.
Okay, to understand the trapdoor, we have to look at how insurance companies attempt to control costs. They do this by building networks.
Okay.
A network is a curated list of hospitals, clinics, and physicians that have signed legal contracts with the insurance company, agreeing to provide services at specific, pre-negotiated, discounted rates.
These are the in-network providers.
Yes. If you utilize an in-network provider, the contract dictates that your care will be processed according to the math we just discussed. The deductible and coinsurance rules apply, and you are protected by the out-of-pocket maximum.
But if you step outside of that approved list, if you see an out-of-network provider,
then the financial protections largely vanish. Because there is no contract between your insurer and that specific doctor, the doctor is not bound by any pre-negotiated discounts.
they can just charge whatever.
They can charge whatever they deem appropriate. The insurance company might pay a fraction of the cost, or they might refuse to pay anything at all. And crucially, the money you spend on out-of-network care often does not count toward your out-of-pocket maximum.
The source uses the word insidious to describe this process, and that is an important word. Insidious means proceeding in a gradual, subtle way, but with harmful effects.
Exactly.
It implies that falling into this trap isn't always a conscious choice the patient makes.
The insidious nature of networks is best illustrated by examining the structure of the American hospital. The assumption most people make is that a hospital is a unified corporate entity,
Yeah.
and that all the doctors working inside the building are employees of that hospital.
That would be the logical assumption. I mean, the logo is on the building, the doctors wear badges with the logo.
But the reality is far more complex. Hospitals are essentially real estate operations that provide the infrastructure, the operating rooms, the beds, the nurses.
Okay.
However, many of the highly specialized physicians who practice inside that building, specifically emergency room doctors, radiologists who read x-rays, and anesthesiologists, are independent contractors.
Wait, really?
Yeah, they belong to separate medical groups that operate independently of the hospital's administration.
So a single building is actually a nesting doll of dozens of different private businesses.
Precisely. And each of those independent medical groups negotiates their own separate contracts with insurance companies.
Which leads directly to the nightmare scenario the source outlines. You need a planned surgery. You do your due diligence. You verify that the hospital facility is in-network. You verify that your primary surgeon is in-network. You walk into the hospital confident that your financial exposure is capped by your out-of-pocket maximum.
And the surgery is a success. You go home to recover, and 3 months later, you receive a bill for $20,000 from the anesthesiologist who was assigned to your operating room.
Because while the hospital and the surgeon were in-network, the independent contractor who put you to sleep was out-of-network.
Exactly.
The concept of a surprise medical bill fundamentally breaks the standard rules of commerce. We are talking about a consumer who is literally unconscious on an operating table.
Yep.
How can an incapacitated person consent to a financial transaction? I mean, if you order a meal at a restaurant, you don't receive a separate bill weeks later from the independent contractor who chopped the onions.
That's a great way to put it.
The burden of verifying the complex web of contracts is placed on a patient who has no ability to choose the staff assigned to their room.
It highlights a massive inefficiency and asymmetry of information in the market. The patient is held responsible for the administrative disjointedness of the facility. Now, the source does provide a critical legislative update here.
Okay, good.
In 2022, the U.S. Congress implemented the No Surprises Act. This was a direct legislative response to the outcry over these exact scenarios.
What does the No Surprises Act actually do? Does it ban the practice entirely?
It attempts to hold the patient harmless in specific situations. It generally makes it illegal for out-of-network providers to send these massive balance bills to patients for emergency services or for non-emergency services provided at an in-network facility without the patient's explicit prior written consent.
Okay, so who pays?
The law forces the insurance company and the out-of-network doctor into a binding arbitration process to figure out the payment between themselves, leaving the patient out of the dispute.
That sounds like a massive victory for the consumer. But the source text still includes a warning that surprise bills still happen. If the law was passed, why is it still a survival skill to watch out for them?
Because the labyrinth is remarkably resilient. The law has loopholes. For example, ground ambulances are entirely exempt from the No Surprises Act.
Of course they are.
Furthermore, administrative errors are rampant. An out-of-network billing department might simply ignore the law and send the bill to the patient anyway.
Just hoping they pay it.
Either through an automated system or hoping the patient simply pays it out of fear. The patient is legally protected, but the burden of proofs, the requirement to know the law, call the billing department, cite the No Surprises Act, and file a grievance, still falls on the recovering individual.
You are presumed guilty of the debt until you prove your legal innocence.
That's a good way to frame it.
So the ultimate strategy to avoid the network trapdoor and the billing nightmare is to control every aspect of your entry into the system. You have to know exactly which door to walk through the moment you experience a biological symptom.
This brings us to the hierarchy of care, because making the wrong choice regarding where you seek treatment doesn't just result in longer wait times. It dictates the financial multipliers applied to your care.
The American system forces the patient to self-triage. Let's examine the 4 tiers of this hierarchy, starting at level 1. The primary care physician, or PCP.
The PCP is your designated general practitioner, an internist or family medicine doctor who manages your overall health history. They handle routine checkups, vaccinations, and the management of chronic conditions.
Okay.
From a financial perspective, this is the most controlled environment. You pay a standard, low copay, and the billing is predictable.
But the source notes a significant functional limitation with the PCP tier.
Time. The system is heavily bottlenecked at the primary care level. Booking an appointment for a sudden illness can take days or even weeks.
All right.
If you develop a severe ear infection on a Tuesday, your PCP likely cannot see you on Wednesday.
Which forces the patient to escalate to level 2, urgent care.
Urgent care clinics are a fascinating market response to the PCP bottleneck. They are walk-in medical facilities, often located in highly visible retail spaces like strip malls. They are designed to handle immediate, non-life-threatening medical issues. If you need a few stitches for a kitchen cut, an X-ray for a rolled ankle, or a rapid flu test, this is the appropriate facility.
And the economics of urgent care.
They operate on a slightly higher but still fixed copay model, usually ranging between $50 to $150. You sacrifice the continuity of seeing your regular doctor in exchange for immediate access to a physician you have never met.
Then we have level 3, which the source emphasizes has exploded in popularity, particularly post-pandemic, telemedicine.
Yes, this is the virtualization of the lower acuity triage. Patients use a smartphone app to initiate a video consultation with a doctor licensed in their state. The patient describes their symptoms, the doctor makes an assessment, and they can electronically route a prescription to a local pharmacy.
It removes the physical infrastructure entirely, and I assume that is reflected in the cost.
It is the most financially efficient option. Telemedicine visits often carry a copay of $10 to $25, or are sometimes offered entirely free by employers trying to keep their workforce out of more expensive facilities. It is highly effective for issues like sinus infections or mild rashes.
But all 3 of those tiers assume the patient is relatively stable. That brings us to level 4, the absolute top of the hierarchy and the option of last resort, the emergency room.
The ER is designed for acute traumas and life-threatening emergencies, heart attacks, severe bleeding, strokes. The source is unequivocal in its warning here. Utilizing the ER for a non-emergency is one of the most devastating financial errors a patient can make.
The source notes that walking into an ER for a minor issue can easily generate a bill between $3,000 to $10,000.
Easily.
Let's analyze why the premium is so high. We have to discuss a specific piece of federal legislation mentioned in the source. EMTLDA.
Right. EMTLDA is the Emergency Medical Treatment and Labor Act, passed in 1986. It mandates that any hospital emergency department receiving Medicare funding, which is virtually all of them, must stabilize and treat any individual who presents with an emergency medical condition.
Regardless of their ability to pay.
Regardless of their insurance status, national origin, or ability to pay, yes.
It is a federal guarantee that you will not be allowed to bleed to death on the sidewalk simply because you forgot your wallet. It is a universal safety net grafted onto a private system.
It is. However, it creates a massive economic paradox.
Yeah.
The law requires the hospital to provide the life-saving labor and materials, but the federal government does not adequately reimburse the hospital for that unfunded mandate.
So the hospital is legally forced to provide a service that they know a percentage of patients will never be able to pay for.
Precisely. And how does a business survive when mandated to give away products for free?
They raise the prices for everyone else.
Exactly. The staggering costs associated with the ER are a direct reflection of the immense overhead required to maintain a facility staffed 247 with specialized trauma surgeons and advanced imaging equipment, combined with the need to subsidize the uncompensated care provided to the uninsured.
Which means the law says they must save your life, but it absolutely does not say they have to do it for free.
No.
The financial reckoning is simply delayed until you are discharged. And the way that bill arrives is its own unique form of torture.
The fragmentation we saw with the anesthesiologist applies to the entire ER experience. The source warns that a single visit to the emergency room rarely results in a single invoice. You might receive half a dozen separate bills over the course of several months.
Let's break down those bills. Who is charging you?
You will receive a facility fee from the hospital simply for occupying the room. You will receive a professional fee from the emergency physician who evaluated you. If you had blood drawn, the laboratory sends a bill. If you had a scan, the radiologist who read the image sends a bill. And if you arrived via emergency transport, you will receive a bill from the ambulance company.
The ambulance? We have to spend time on this because for international visitors, this is the detail that truly shatters their understanding of how a society should function.
Completely. In a universal system, emergency transport is viewed as an essential municipal service. It is funded collectively through taxation, operating on the same civic logic as the fire department.
Right. If your house is on fire, the fire trucks arrive, extinguish the blaze, and they do not present you with an invoice for the water they used.
But in the American system, ambulances are frequently operated by private, for-profit corporations or by municipal services that contract out their billing.
And because the patient in the back of an ambulance is entirely captive-like, they cannot negotiate. They cannot shop around for a cheaper ride. The prices are astronomical.
Astronomical. The source cites a standard ambulance transport as costing anywhere from $500 to over $2,500.
Wow.
Furthermore, because ambulances are mobile entities, they are almost universally out of network, bypassing the very protections the patient pays their premium to secure.
This reality has birthed a phenomenon that the source highlights as a dark joke among Americans, though it is entirely factual. Taking an Uber to the hospital.
Yes. The financial dread associated with an ambulance bill is so acute that patients experiencing severe medical distress will open a ride-share app on their phone, request a civilian driver in a Honda Civic, and sit bleeding in the back seat just to avoid a $2,500 transport charge.
The financial anxiety actively overrides the biological instinct for self-preservation.
It is a terrifying calculus to perform while in pain.
Let's test how well a patient needs to understand this hierarchy by running through the practice scenarios provided by the C2 English instructors. You listening, imagine you are the patient. Apply the hierarchy before the expert gives the answer.
Okay, the goal here is balancing medical necessity against financial exposure.
Scenario 1. I am playing basketball and I severely sprain my ankle. It is painful and swollen, but I am conscious, breathing fine, and I can hobble to a car. Do I choose the PCP, urgent care, telemedicine, or the ER?
You choose urgent care.
Okay.
A sprained ankle requires an X-ray to rule out a fracture, which immediately eliminates telemedicine. Your PCP cannot accommodate a same-day appointment. However, the injury is not life-threatening, making the ER an incredibly expensive overreaction.
Right.
Urgent care will charge a fixed $100 copay, perform the x-ray, provide a brace, and discharge you.
Perfect alignment of acuity and cost. Scenario 2. I wake up with a persistent cough, a scratchy throat, and a mild fever. The symptoms have lasted for 2 days.
This is the ideal use case for telemedicine. You do not require physical palpation or specialized imaging. A physician via video link can assess the progression of the symptoms, differentiate between a viral and bacterial infection, and route a prescription for antibiotics or cough suppressants directly to your pharmacy.
And the cost.
Your financial exposure is limited to a $15 copay.
Excellent. Scenario 3. I am sitting on the couch and experience sudden, crushing chest pain radiating down my left arm, accompanied by severe shortness of breath.
This represents a potential myocardial infarction, a heart attack. This is a level 4 trauma. You bypass all lower tiers, dial 911, or proceed immediately to the emergency room.
So in this case, cost is secondary.
In this specific scenario, the biological risk of death eclipses the financial risk of the transport or the facility fees. You do not attempt to self-triage or price shop while your heart muscle is dying.
Exactly. The biological imperative wins. So you navigate the hierarchy perfectly, you survive the physical trauma, you see the appropriate doctor, and they hand you a piece of paper, a prescription for medication. You might assume the complex decision-making is over, but walking into an American pharmacy introduces an entirely new, highly unregulated economic battleground.
If the hospital billing system is a labyrinth, the prescription drug market is a wild frontier. The source establishes a stark baseline fact. The United States consistently reports the highest prescription drug prices in the developed world.
The example they use to illustrate this is insulin, and it is a perfect case study. Insulin is not an elective lifestyle drug. It is a biological requirement for individuals with type 1 diabetes. Without it, they die.
And the manufacturing economics of insulin are well documented. A single vial costs approximately $10 to produce. The source notes that in systems like Canada or the European Union, the market price reflects that cost of production, often retailing for around $10 to $15.
Okay.
In the United States, that exact same vial containing the exact same chemical compound can be priced at over $300.
A 3,000% markup on a life-saving chemical. How does the market architecture allow for that discrepancy? Why is it $10 just across the border but $300 here?
It comes down to the presence or absence of a unified negotiating entity. In a universal healthcare system, the national government acts as a single monopsony buyer. Yes, the government approaches the pharmaceutical manufacturer and dictates terms. We represent 50 million citizens. We have determined a fair profit margin is X. We will pay $12 for this vial of insulin. If you do not accept $12, you cannot sell your product in our country.
The sheer volume of the threat forces the price down.
Exactly. But the U.S. system doesn't have a single negotiator.
Right.
The U.S. market is fractured among thousands of different private insurance companies, employers, and pharmacy benefit managers. There is no unified leverage. Furthermore, the U.S. government has historically been legally barred from directly negotiating drug prices for Medicare.
So they just charge whatever they want.
As a result, pharmaceutical companies operate on the principle of charging whatever the market will bear.
Which means the sticker price, the MSRP of the drug, skyrockets, and patients are left to navigate the fallout. The source outlines 4 specific survival strategies that consumers must employ just to afford their necessary medications.
Strategy 1 is the foundational defense, substituting brand name drugs for generics. When a pharmaceutical company invents a new compound, they are granted a patent, giving them a monopoly to sell the drug at premium prices to recoup research and development costs.
But those patents eventually expire.
Right. When they do, competitor manufacturers can produce the exact same active chemical ingredient. These are generic drugs. They are heavily regulated by the FDA to ensure they are chemically identical and functionally equivalent to the brand name. But because there is no research cost to recoup, the price drops drastically.
So always ask for the generic.
A strategy is to constantly question your physician. Is there a generic equivalent for this prescription?
That makes logical sense. But strategy 2 is where the U.S. system diverges from global norms in a truly bizarre way: pharmacy shopping.
In almost any other developed nation, the price of a specific medication is regulated and standardized.
Yeah.
If you walk into a pharmacy in London or Berlin, the drug costs the same amount as it does at a pharmacy 50 miles away.
But the source explicitly states that in America, you have to shop around for pills the way you shop for airline tickets.
Because the price of the drug is treated as a retail commodity, It fluctuates wildly based on the specific contracts between the pharmacy, the distributor, and the insurance company.
Wild.
A month's supply of cholesterol medication might cost $100 at a large chain pharmacy, $40 at an independent local pharmacy, and $20 at a grocery store pharmacy located directly across the street.
And this inefficiency has spawned an entire secondary industry. The source mentions third-party apps like GoodRx. Patients download an app, type in the name of their medication, and the app displays a map showing the varying prices at every pharmacy within a 5-mile radius, offering discount coupons to bypass their own insurance if the cash price is cheaper.
It forces the patient to become an active commodities trader for their own health.
Which leads us to strategy 3. And I have to admit, seeing this taught in an English language class as a standard survival tactic is astonishing. Strategy 3 is pill splitting.
Yeah. Pill splitting is an economic workaround to a pricing anomaly. Often, a pharmaceutical company will charge roughly the same price for a 50-milligram pill as they do for a 100-milligram pill of the same medication.
So the active ingredient isn't what drives the cost? The physical unit is what is priced?
Correct. Recognizing this, patients will ask their physician to prescribe double the required dosage. If the patient needs 50 milligrams daily, the doctor writes a prescription for 100-milligram pills.
Okay.
The patient takes the larger pill home, purchases a specialized pill-cutting tool, or simply uses a kitchen knife, and physically halves the medication. By taking half a pill each day, they effectively reduce their monthly medication expenditure by 50%.
Think about the implications of that.
Hey.
We are discussing one of the most technologically advanced medical infrastructures in human history. We have surgical robots and AI-driven diagnostics.
Yep.
Yet the sanction mechanism for millions of citizens to afford their daily medication involves sitting at a kitchen table and physically hacking their pills into pieces to exploit a pricing loophole.
It is a stark illustration of how market inefficiencies force consumers into physical workarounds. And when the workarounds fail, they turn to the final strategy, the source nodes. Buying from Canada.
Physically crossing international borders or using online international pharmacies to bypass the U.S. market entirely?
While technically a violation of federal importation laws, it is a widely practiced and largely tolerated desperate measure. American citizens utilize the regulated pricing of the Canadian or Mexican markets to access the exact same drugs manufactured by the exact same global pharmaceutical companies simply because their own domestic market refuses to regulate the retail cost.
So you've utilized your generic workarounds, you've checked your discount apps, you've split your pills, and you have survived the biological event. You are back home, recovering, and then the final phase of the healthcare journey arrives in your mailbox.
The administrative aftermath. The paperwork, the negotiation, and the EOB.
The source dedicates significant time to a document called the Explanation of Benefits, or the EOB. And they emphasize a fundamental rule. The EOB is not a bill.
It is a profound point of confusion because an EOB looks exactly like an invoice. It features dates of service, alarming dollar amounts, and an aggressive layout.
Right.
But an EOB is actually a transcript of the financial negotiation between your healthcare provider and your insurance company. It is a communication tool, not a demand for payment.
Let's break down the columns on that document. Why does it look so terrifying?
The first column usually shows the billed amount. This is the hospital's charge master price, the absolute maximum retail sticker price they attempt to charge. It is almost always a wildly inflated number.
It's like the MSRP on a car, but a car nobody actually expects to pay full price for.
Exactly. The second column shows the allowed amount, or the negotiated rate. This is the much lower price that the insurance company contractually agreed to pay for that specific service.
Okay.
The third column shows what the insurance company actually paid out of their funds. And the final column shows patient responsibility, the portion you theoretically owe based on your deductible and co-insurance calculations.
The danger, according to the source, is that patients receive this EOB, see a massive number under patient responsibility, panic, and immediately write a check to the hospital.
Which is a critical error. You must wait until the hospital sends their actual official invoice. Once you have both the hospital bill and the insurance EOB, you sit down and reconcile them. You ensure the numbers match perfectly.
And why is that reconciliation so vital? Because the source states something quite alarming. Medical billing errors are ubiquitous.
Oh, they are everywhere. The complexity of the coding system guarantees errors. A clerk might enter the wrong billing code, a procedure might be listed twice by mistake, or an in-network doctor might accidentally be processed as out-of-network.
And if you don't check it.
If you blindly pay the bill without cross-referencing the EOB, you are subsidizing those administrative errors.
But the source doesn't just warn the listener. It offers genuine empowerment. It provides insider strategies for fighting back against the final bill. Because a key takeaway here is that medical bills are not static edicts. They are starting points for negotiation.
This is a lever that patients rarely realize they have. If you receive an accurate but unaffordable bill from a hospital, you do not simply default and let it ruin your credit. You engage the billing department.
Right.
Hospitals are well aware that collecting medical debt is difficult, so they are often highly receptive to negotiation.
What specific tactics does the source recommend?
First, you can request an itemized bill. Demanding to see every single charge individually often causes the hospital to quietly remove inflated fees for minor items, like charging $20 for a single aspirin.
Good to know.
Second, you can ask for a prompt pay discount. If you owe $3,000, you can call the billing department and offer to pay $2,000 immediately in a lump sum if they agree to waive the remaining $1,000. They will frequently accept the guaranteed cash over the uncertainty of a payment plan.
And there's another term the source introduces for those who genuinely cannot pay. Charity care.
This is a vital mechanism tied to the tax code. A significant percentage of hospitals in the United States operate as nonprofit entities. In exchange for avoiding millions of dollars in taxes, the federal government requires them to provide a certain amount of charity care or financial assistance to low-income individuals.
So what does that mean for the patient?
Depending on your income relative to the poverty line, a nonprofit hospital can legally wipe out your entire bill or drastically reduce it.
But, and this is a crucial caveat, the hospital is not going to proactively offer this to you.
No, they will not attach the application to your bill. The burden of discovery rests entirely on the patient. You must actively call the financial office, use the words financial assistance program or charity care, and demand the application.
This all sounds so exhausting. The constant vigilance, the negotiation, the tracking. It leads to a question the podcast instructors say they get constantly from their international students. Can I just opt out? Can I just choose to be uninsured and risk it?
Well, from a purely legal standpoint at the federal level, yes, the individual mandate penalty was largely eliminated, though a few states impose their own tax penalties. But opting out is effectively playing Russian roulette with your entire financial future.
The source outlines the reality of the uninsured gamble. If you are young and healthy, it feels like a mathematical win to keep that $2,000 monthly premium in your pocket.
Sure.
But a single unpredictable event, a car accident, an appendix bursting, a sudden cancer diagnosis, can generate a medical bill exceeding $500,000 in a matter of weeks.
And that level of debt triggers a cascade of consequences that extend far beyond the hospital walls. When an unpaid medical bill is eventually sold to a collections agency, it acts as a nuclear bomb on your credit score.
Let's discuss the gravity of the credit score, because in the American financial ecosystem, your credit score is your identity.
It dictates your ability to participate in the modern economy. A plummeting credit score means you'll be rejected when applying to rent an apartment. It means banks will deny you a loan to purchase a vehicle, which you need to get to work.
Right.
It means you cannot secure a mortgage. In many states, employers run credit checks on job applicants, meaning a medical debt can actively prevent you from securing employment to pay off that very debt.
The ripple effects of a single biological event can effectively lock you out of the basic functions of adult life for 7 years.
Which is why the source instructors hammer home their ultimate survival guide. Let's recap the core tenets they want their listeners to memorize.
Rule 1. Scrutinize your open enrollment options. Never just look at the monthly premium. You have to analyze the deductible, the coinsurance splits, and the absolute out-of-pocket maximum to understand your true risk exposure.
Rule 2. Verify and constantly re-verify your networks. Check the status of the hospital facility, the primary surgeon, and critically, the secondary specialists like anesthesiologists and radiologists.
Rule 3. Keep meticulous, obsessive records. Save every piece of correspondence, file every explanation of benefits, and log the names and dates of every representative you speak to on the phone.
Rule 4. Demand transparency up front. Ask for written estimates before elective procedures, and always ask your pharmacist if a cheaper generic alternative exists.
And Rule 5. Advocate and appeal. Never accept a denied claim or an exorbitant bill as the final answer. Negotiate the balance, demand itemization, and leverage charity care programs.
The instructors wrap up their lesson by stating that in the American system, knowledge is your most powerful tool. If you do not understand the rules of the game, the system will optimize for its own financial health, not yours.
It is remarkable to reflect on the fact that this entire analysis originated from an English language lesson. The instructors aren't just teaching grammar, they are teaching defensive consumerism. The jargon-deductible coinsurance in-network EOB is a systemic barrier. If you don't speak the language, you cannot navigate the labyrinth.
The linguistic complexity is a mirror of the administrative complexity. Both require intense, active decoding.
It is a heavy reality to process. We've journeyed from understanding the initial shock of the premium cover charge through the punishing math of deductibles and coinsurance into the insidious traps of out-of-network billing.
Yeah.
We've mapped out how to self-triage through the hierarchy of care to avoid a catastrophic ER bill, navigated the highly volatile prescription drug market, and learned how to aggressively dispute the final invoice to protect our financial identities.
It requires a fundamental paradigm shift. It forces a realization that in this specific market, interacting with healthcare is not just a biological event. It is a high-stakes economic engagement.
And as we bring this deep dive to a close, I want to leave you with a final thought to ponder, something that builds on the economic realities we just discussed, particularly the devastating impact medical debt has on a credit score and a person's ability to rent an apartment or secure a job.
Consider the broader implications of that mechanism. In discussions about the United States, there is constant debate regarding economic inequality, wage stagnation, and the difficulty of upward mobility.
Right.
But if a single broken leg or a single surprise bill from an out-of-network anesthesiologist can trigger a credit collapse that locks a family out of the housing market for a decade,
how much of what we culturally define as purely economic inequality or financial mismanagement is actually just disguised medical bad luck?
It raises a profound question. Is the true cost of this healthcare infrastructure much, much larger than just the sum of the hospital bills? Are we looking at a systemic design that doesn't just extract wealth, but fundamentally suppresses economic mobility for those who happen to get sick? It is a systemic feature worth questioning.
It really shifts the perspective from individual responsibility to structural impact. A broken bone is a biological reality, but the economic earthquake that follows is a human invention. Thank you for joining us for this deep dive. Keep exploring these systems, keep challenging the mechanics of how things work, and keep seeking out those vital insights. We will see you next time.